It's a delight to be here, and even more so to have my very good friend and colleague, Berith Hedberg, with me. Berith is in a unique position in Sweden in that she straddles the academic world as a senior lecturer, soon to be assistant professor, and the world of care delivery as a practitioner. So she does what we call bridging the gap between academics and actual practice, and has been a true friend to me. She also bridges the gap when Americans show up and can't find their way around Sweden. So she's been a great friend. So we are pleased to be here. It's just exciting for me to be able to set the stage for the work that has been the study that I've been doing here with my colleagues here at Dartmouth around microsystems. I'm going to talk a little bit about that. And then the fun thing is having the theory being adapted in Sweden and other countries, and seeing how focusing on the front line of care delivery, that interface between patients, families, and healthcare professionals, can lead to new designs. So I'll give a little background about microsystems, and then talk about the patient-centered care in Sweden, which I've learned a phenomenal amount about in the country, and also with different values and approaches, what they've been able to do. And Berith will be sharing two novel approaches, specifically the use of quality registries and a specific case about rheumatoid arthritis. And then the other story will be about the Together program, which when I first heard this I was a little surprised, but it certainly knocked my thinking out of the box about patients doing self-dialysis. So if you think about all of those implications of shared decision making and co-design, that's pretty substantial. So when we think about systems of practice and interventions, I think what's really important is in our work we talk about self-care, there's the individual and the provider care, clinical microsystems, which includes interacting and coordinating care by interprofessionals, and the use of technology, and patients and families are part of the microsystem. The mesosystem, by definition, is two or more microsystems, so if you think about the continuum of care that a patient travels, the macro system being the larger organization, and then the geopolitical and regional issues. If you think within what's happening here in the United States, where we look at putting the Affordable Care Act here and then moving into statewide initiatives, there's been many states like Massachusetts have been doing care redesign and improvement, moving down to ACOs that we heard some stories about, and where we're moving toward to the patient-centered medical home, which is actually the primary care in a microsystem, and how patients and providers work together. This model works very well because we find that sometimes, and most of the time, it's not well aligned, and how do we work to align each level of the system. We did in 2002, Jean Nelson, Paul Batalden, Julie Moore, Thomas Huber, you can see the others, we actually went out and studied some of the high-performing frontline clinical teams, or microsystems as we call them, to find out what made them so special. How were they able to achieve the results that they were getting, and what could we learn from them to be able to help others become high-performing microsystems? By definition, we talk about this clinical microsystem being a small group of interprofessionals who come together regularly with the patients that they serve, so it includes the patients and families, to provide care. It has clinical and business aims, linked processes, shared information environment, and there's measurable outcomes that are a result of this small unit. Many of you might think about an emergency department or 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 primary care, but it's that space where care and services are delivered. The success characteristics that we found in the high-performing microsystems are shown here, and just broadly, the categories looking at, there was strong leadership in the microsystem and also in the organization. And I think that's something that I haven't heard a lot of talking about here in the last few days, is what is the leadership that's required at the microsystem level and the other levels to ensure that shared decision making is included in all of the practices. Looking at staff, intense development and orientation of patients and staff, and continuous development, and becoming this team that realizes we're interdependent on each other. And I was thinking about this morning when we saw that for shared decision-making success factors, staff engagement, having the right person at the right time, and also automation and workflow fits very nicely in this model that we've been studying for several decades. Patient involvement is very important in understanding patients and families and their needs, and how do we link with the community. The fourth category being looking at our results and how do we do improvement? How do we all get together around improvement? And in the middle, information and information technology, tying all of this together. So you think about these elements in one unit of care or in multiple units, it outlines some of the work that needs to be done when you're looking to change or innovate how we provide care, including shared decision-making. How we do this is we have a baseline measure in understanding what we call the 5 Ps. Sarah talked this morning about structure, process, and workflow. That's very much ingrained in the work that we do. Before we can help those at the front line make innovative changes, they have to understand their current state. So the structure and process model that we use is what we call the 5 Ps. Understanding their purpose, understanding the populations of patients being cared for, who are the professionals, what are the processes or workflows of care, and what are our patterns. And in thinking about this in the last 2 days, I've decided we really need to put shared decision-making into our assessment tools because we don't have that there now. And I think sometimes we find it under patterns, where you find some units that regularly engage patients and families in decision-making or co-design. But we have published materials we need to revise to bring this more prominently to the assessment phase. The process and the workflow, this is part of our assessment that we do when we're trying to engage all members of a frontline team to be able to provide care and improve care. And we look at the outcome measures. What are the outcomes that this unit is currently providing? So that leads to redesign, and these are the workbooks that we have that I said we need to revise and rethink about to make sure shared decision-making is in there and that people raise the question. Just by raising the questioning raises awareness, and I think there's some good tools that we could put in here based on all the work that you're doing to be able to move to this idea of a redesigned, innovative unit that has the right person doing the right thing at the right time, every time. And using that technology that ties all of the success characteristics of a microsystem together to help us be able to remind us and be able to do this in our regular workflow. So working and focusing on the clinical microsystem, we find these are the usual reasons. It's the building block of a healthcare system, or as you could say, the ACO. It's also the clinical policy and use. It's where workplace, professional joy, staff satisfaction grows out of the frontline unit, and also patient satisfaction is controlled here. It's also where good value and safe care is made, and it's where we have health professional formation after our original education. And for me, being a nurse, it's where everything happens with, for, and to the patient and family. We should pay a lot of attention to this intersection between patients, families, and into professionals. So our colleague, Stefan Lindblad, who is at the Karolinska Institute in Stockholm, his adaptation of the microsystem is what he calls the smallest unit or atom of healthcare. And he's done a lot of work of engaging patients and the provider through using and leveraging informatics in very clever ways. And at this point, Berith is going to be talking with us about it, but I want to talk a little bit about Jönköping, Sweden. We have our bearings here in Europe, where Sweden is, and Jönköping is here with these 3 different counties here that compose the different, you can see here, 3 hospitals, 51 primary care centers, and they have 330,000 inhabitants that they're providing care for. And they have a blend of healthcare system, government, and professional educators looking together how to create the ideal healthcare system with the best outcomes. So Berith will share a couple of stories with you that really get at the point of leveraging and activating the microsystem to be able to achieve best outcomes.
Thank you, Margie. And I will also say good afternoon to you, and also express my gratefulness for being invited to this summer institution. It is a challenge for me, and it's also very wonderful to share my experience with yours. So my presentation is about two novel approaches for informing patient-centered care in Sweden and specifically in Jönköping. First, I will give you a brief view of how the concept of patient-centered care is defined in Sweden, and then talk about our national quality registries, which contains of individual-based data on problems, diagnosis, treatment interventions, and outcomes. Finally, I will give two examples of co-designed care. One national applied and one applied at Ryhov Hospital in Jönköping. So in 2010, the first research center on person-centered care in Europe started up in Gothenburg, supported by the Swedish government. The research is focusing on care for patients with chronic diseases. And they have defined and told us what kind of requirements we should have. And they formulated this in 3 routines. So it should be initiating the partnership. So it should be based on patient narratives. It should be working with the partnership, and they mention shared decision making here. And also safeguarding the partnership, and they mean we have to document the narratives. Based on 2 surveys, the National Patient Survey and an international survey including 11 countries, an external evaluation was carried out by Elizabeth Doctor, I don't know for sure how to pronounce her name, from US, and Angela Coulter from UK recently have done. And in their analysis, the term patient-centered care has been adapted in difference to its emergence of preferred terminology in widespread use today, both national and international. And that is something interesting about this. So in one part of the country we talk about person-centered care, and in the other side of the country we talk about patient-centered care. So I would like to have your opinions about that later on. So this analysis showed that 1/3 of Swedish patients with healthcare needs reported problems due to inadequate coordination of their care. Swedish patients are among the least engaged by their primary care physicians and involved in their care decision making. So the Swedish Agency for Health and Care Services has recommended 6 steps towards a more patient-centered care. And those 6 steps is what you can see on the screen. So that will be very much challenges for us as researchers, but also for practitioners and patient organizations and everyone. In Jönköping, we have also tried to see how we will deal with the concept of person or patient-centered care. So from the Swedish law, we have taken as goal the involvement of patients, relatives and citizens will be a natural part of the development activities. And why so? Yes, we have to actively use experience and knowledge of patients and their relatives in activities of care development and patient safety. And to do that is to developing processes to make it possible for the patient to engage in their own care, and ensuring that the culture and processes involved supports feedback from patients and their relatives. So we have about 73 certified quality registries in Sweden. The national quality registries contains individualized data concerning patients' problem, medical interventions and outcomes after treatment within all healthcare production. And as you can see here, I have also put patient-reported quality here. And that is a very new approach, you can say, from the government and the state. They want us now, and they will give us a lot of money for developing all quality registries to also be taking in patient-reported outcomes. All of those quality registries are developed by professionals, and they are also financially supported by the government. We have 73 now this year, but we have many more. But every one of the registry will have the potential to be developed, and we have 4 levels. So we have a committee, and they are reviewing all of this. And if you have any more specific questions about quality registry, we have an expert here, Hanna Lundstedt, and she will be happy to answer questions if you have specific questions around quality registries. There is to be certified for a perfect quality registry, and from these 73 we have only 4 registries which has all these 8 outcomes in the measurement or in the register. You can see what they are. In the blue one, it is more patient-reported quality, because that is one of the requirements nowadays. This diagram will show you how many of the quality registries have the different kind of outcome measure. So as you can see, we have a lot of work to deal with and develop more. So I will now go over and give you the first example of a co-designed care, and this example is taken from Staffan Lindblad's work with the Swedish Rheumatology quality register. And Lindblad's research team, they say that they use the unique advantage of national quality registers describing regular clinical practice, and that is what characterizes each patient, which treatment are given, and the health outcome generated. And this is something that support the citation from Elliot Fisher yesterday, saying that if you define the population, you can define the care. And that is exactly what the quality register can do. So this is something that Lindblad and his team has found. It has been a decreased value of inflammation over the past 10 years. And one of the most important values is just that, decreased inflammation, which leads to many other improvements. In his work, he relied on those 6 goals from Institute of Medicine, and he used them to redesign the healthcare. So now I will show you, and you will meet Karin, is a patient.
Yeah. Thank you. I have several hobbies, singing in choir, traveling, but most of all I like the gardening, and the garden is my pride and joy. My disease started 25 years ago with pain in the hand and the feet. I tried to ignore it because I'm a doctor myself, but eventually I have to go to a colleague that give me the diagnosis rheumatism. My disease has been quite severe, so I have had the strongest drugs from the beginning. It was a new life that began. Unfortunately, it didn't last. It has been ups and downs over the years, but still it's much better after the new biological medicines. They are more effective, but still I have to change between drugs, and now I'm on my 4th biological drug. Nowadays I work together with my doctor and the computer for every change in the treatment. I can check my chronic disease at home in between visits. Before I go to see my doctor, I measure my own health. It's easy, I just click on the screen and enter how I feel now.
More and more doctors use national measures from the registry. Today, 25,000 visits per year are reported directly from the clinic to the quality register in rheumatology. When Karin visits me at the clinic, I access the information that she has entered at home. The quality registry uses nationally agreed outcome measures. I can also compare my results with other clinics and also with the best in Sweden. I have invited Karen to use these measures, and she gives me information on how she's doing and the effects and the side effects of the medication.
The internet support system enables me to contribute the management of my own disease. I can monitor the effects of the drugs, how they help me and if they failed. I can better understand my doctor's reasoning when we decide on my medication and how I should take it to get the best result. Now I'm doing fairly well, but we can see together when the disease becomes more active and I need a new drug.
The new drugs are so expensive that there are always questions about the rising costs. I feel confident that the drugs are used in the best way, since I can measure the effects all the time in every patient and at every visit.
Now I have a system to help me take control over the situation. I can use it to compare how it is now and how it has been before. The other day I told my husband I've never been as bad in my disease, but he didn't agree. And we looked together on the data at the internet and realized that I've been worse before. This helps me get through bad periods by myself, since I know I've managed it before. The future is bright. Here in the spring the garden is wonderful and I can work in it. We are soon leaving for a 3-month trip through Europe, and that is a dream of our life. And that hasn't been possible before the new medication.
So related to those 6 goals, and this is what the patient says about this kind of decision aid or shared decision making or co-design. I feel secure despite risk of my drugs. I can see when I need a new drug. I can monitor the effects of my drug. I can manage myself much more. And I can compare my measures with others, and I work together with my doctor now. And from the provider's side, they say that you can see side effects can be reported at the visit, and patient needs-based clinics open tight.
Just want to talk a little bit about open tight. Because of this registry data and the ability to partner with patients, what they've done is stratified their patients to the open type, which means that patients are self-managing. And the open means they don't have regular appointments except for their annual exam, but they can contact the office and the nurse and say, I want to be seen anytime they want. The tight clinics are scheduled appointments regularly with the provider when someone is not stable. So they're able to stratify the work and find more efficiencies in the design of their office practice and have right people doing the right thing based on the outcomes of the patients and their ability to self-manage.
And as you can see, it's a lot more of benefits here. And what's very important in Sweden is the benchmarking opportunity. So patients share the work, and that is something that is something good about that. So we use these goals and direct the curve up and do it together. That is an important point. So the other example is the self-dialysis, and that is a unit in Rehov Hospital in Jönköping. And that unit is co-designed from the Together program, we call it. And when they started to do this program, they realized that patients, relatives, and citizens, they were still utilized as a resource to improving healthcare, and they were asking themselves questions about how can we become better resources for each other together, and how did we do creating this co-design care. Yes, they used a lot of things. They had assignment from the board of the patient safety, so from the leadership, from the leader management, it was okay to do an improvement work. They were looking for good examples, and they find some in UK and also in Norway. They were inspired from articles, and they did workshop together with patients and staff members. And they also created a model called Together. And this model, it is a work the patient, relatives, and employees, they are doing it together. So in this program, staff teams, they are not allowed to come one staff, they have to come there in a team. And the patients are asking to be there, and they are voluntary, patients and relatives. And in this case, it was 3 clinics working together. They had seminars, and they have also, during the time, have presentations on national conferences. So the new unit for self-dialysis was planned, and this is a unit where the patient manages their dialysis treatment by themselves. And to know exactly what to do, they use the PDSA cycle to take the improvement work through those 4 phases. And after the staff had gone through the Together program, they said that they created a more home-like environment. They bought new chairs chosen by the patients. They repainted calm colors on the walls. They adjusted the opening hours when it was best suited for the patients. They gave the patients individual passes to the entrance, and they attracted public interest by the patient's blog. And the voices from the patients, as you can see here, we have talked a little bit during those days about PREM and PROM, or PROM more than PREM, but we have also started to talk about PREM as a patient-reported experience measure. And when we take a look of what Inga-Maj here has told us, it's a lot of PREM values that we should think about very much, and perhaps develop, or of course we should develop measurements from that. So listen to my voice, treat me like a human being, and look into my eyes and think that you are me. Meet me with respect. Let me be involved in my own care, etc. And now you will meet Patrick. He's a man, as you can see, 44 years old. He's employed and single father with 4 children, and he has an apartment. And he has his diabetes for about 20 years, and renal disease for 10 years, and self-dialysis for 2.5 years.
Vid länssjukhuset Ryhov i Jönköping har det funnits en självdialysenhet sedan flera år. Men i våras invigdes en ny paviljong med 12 platser, 8 fler än tidigare. Just nu är det 14 patienter och de nyttjar platserna enligt ett schema.
Ibland kommer jag klockan 6 och då öppnar jag med kort och då är jag helt själv här. För att personalen börjar inte från klockan 7. Och vi som har kort, det är vi som sköter oss helt själva.
Paviljongen kom ju till nu i april, har vi invigt det. Och tidigare har vi försökt att få att dialysen ska utvidgas. Men så har det inte funnits pengar och resurser. Och då känner man, nej, inte nu igen. Men nu när det här är klart så känns det som att det var rätt timing. För det är nu vi har börjat mer tänka självdialys, att de flesta ska kunna det. Innan var det nog att det hade blivit som en vanlig dialys, och så har man kanske tagit ett hörn.
Det första jag gör när jag kommer på morgonen är att jag startar maskinen så att den gör sitt självtest. Sen tar jag min vagn och går ut och hämtar mina grejer. Efter det så börjar jag klä maskinen och sätter dit slangar och filter och lite annat. 20 minuter för att bli färdigt allt sammans innan jag kan börja sticka nålarna. Jag sköter alla momenten från början till slut helt själv. Själva dialysen tar ju 4 timmar när jag är kopplad i maskinen. Sen ska man koppla innan och man ska städa efteråt. Ja, 25 timmar i veckan ungefär.
Normalt så styr ju dialysen livet, för du har måndag, onsdag, fredag kanske klockan och så är det. Men vi skulle vilja att livet styr dialysen. Så att om du behöver lämna barnen eller du behöver hämta dem eller du jobbar, så ska du komma efter där. För du måste ha dialys. Men du kan försöka få det att anpassas till dagen som du har det.
Hemdialys är ju inget alternativ för mig. För att jag bor i hyreslägenhet och har lite utrymmesbrist. Jag är ju här 4 dagar i veckan och trivs jättebra här. I väntan på att få en njure då så funkar det här jättebra. Som sagt var.
So we will stop the video here because we want to have some reactions and some reflections from you.